I'm a medical oncologist specializing in the care of patients with thoracic malignancies. As part of my role, I not only take care of patients, but I'm also an active clinical and translational investigator. What that means is I'm someone who focuses on developing clinical trials, ranging from phase 1 clinical trials all the way to phase 3. But I'm also a translational investigator, and I'm particularly interested in understanding biomarkers of response to therapy, as well as mechanisms of resistance to therapy. So much of my background was in studying targeted therapies and mechanisms of resistance to targeted therapies. And over the last several years, I've tried to take that same infrastructure and approach and apply that to immune checkpoint inhibitors, where I think so much remains to be discovered. Targeted therapy generally relies on the principle of finding genetic alterations and oncogenic drivers within a given cancer. These are dependencies that lead to a state of oncogene addiction. And because the cancers are addicted to a particular signaling pathway, we can use precision medicine to, in most cases, use a tyrosine kinase inhibitor to inhibit those signaling pathways, which generally leads to tumor cell death. At the heart of targeted therapies, though, is really doing genotyping of the tumor, either the tumor tissue itself or liquid biopsies, and really pairing that with the corresponding targeted therapy. By contrast, cancer immunotherapy really relies on a very different principle. We recognize that cancers really are a disease of the genome, and that with the accumulation of additional genetic mutations in a given cancer, it begins to look more foreign to the immune system. And if there are the right genetic alterations within a given tumor, we call these neoantigens that can be recognized, then this can elicit an anti-tumor immune response. What cancer immunotherapies aim to do is really to stimulate the host's native anti-tumor immune response. Cancer immunotherapy is a very, very broad term, but really what's been a game change over the last several years are cancer immunotherapies known as immune checkpoint inhibitors. Essentially, these agents block one of the brakes on the immune system, these so-called negative regulators of the immune response, and that has really led to profound anti-cancer responses, and also led now to FDA approval in more than 15 different cancer types. We do recognize, however, that while these checkpoint inhibitors have really been game changers, they only work in a subset of patients, approximately 20%. And so I really view the next decade of research is going to be focused on biomarkers of response to checkpoint inhibitors, as well as trying to develop new combinations of agents to really boost the response rates that we're seeing to these agents. So in non-small cell lung cancer, which is the dominant disease that I treat, in 2002, we rarely talked about even 1-year survival rates. Now we're talking about 3 and 5-year survival rates. And with cancer immunotherapies, we're seeing that about a quarter of patients with advanced non-small cell lung cancer are living 5 years and longer. So this has been completely transformational in how what my clinic looks like. I'm having patients come into my clinic 4, 5, 6 years after starting on therapy. But it also underscores where we need to go, because unfortunately only a minority of patients are having those really deep and durable responses. And so, our major efforts right now is to identify who are those patients and how can we design better clinical studies to actually increase the frequency of those really notable responses.